Get started right now. All right, so it is 12 o'clock. We are going to get started. Today is October 28th, 2021. If you're watching a recording of this webinar, a lot of this has probably changed. So go to cdc.gov for the most up-to-date information about COVID-19 pandemic and about COVID-19 vaccines. So we were just saying we're still getting folks that are logging on. We know that the first few minutes, people are kind of gathering their lunches and stuff. We're really excited to have lots of new people who haven't been to COVID tips yet, but you are old friends and go to the regular tips. Most of you are, it looks to be from pediatric practices. We know you are elbow deep in getting ready for hopefully to be able to start administering this vaccine to your younger patients, ages 5 and up next week, but not happening yet. We're still focused on vaccinating people 12 and over. So I am Rebecca with the Vaccine Coalition, TAPI, and Mrna, do you want to say hi?
I am Mrna with Maricopa County Department of Public Health and a member of TAPI.
Yes. And Mrna is going to have kind of our first half of our presentation today. We're going to go over boosters. We have a little bit about kids and want to make sure that you get lots of your questions answered, especially those of you who've been just starting to do orders for the first time and things like that. So if you're new, use the chat box as much as you can. And we'll pause throughout to make sure that you have time to unmute yourselves and ask questions. And I'm going to ask Jen Tinney to unmute yourself. Are you able to stay on for 15 minutes after Jen? Because Mrna and I are not able to.
I can stay on for 15 minutes after and go through some questions. Absolutely.
Perfect. And Jen, as many of you know, is our billing expert as well. So if you have billing questions and we don't get to them during the regular hour, stay on at 1 o'clock and just talk over somebody else so you can get your questions answered before you go back to your patients. The second half of our session today is going to be with JJ Rico. He's the CEO of the Arizona Center for Disability Law. And we are really excited to have JJ here with us today to talk about how to make sure that all of our residents can access vaccine and other healthcare services too at your site. So every tips, we start with just a really quick recap of where we're at in this pandemic, which has been going on what feels like since the beginning of time, but really only for about 22 months. 1,159,000 cases of COVID-19 in our state. And sadly, 21,033 people have lost their lives to COVID-19 in our state. The Arizona Public Health Association actually released a report this week done by some of their members who are epidemiologists looking at death rates. And sadly, COVID for the last year. So they looked at deaths from St. Patty's Day, 2020. That's an important day. That's the day of our stay home, stay safe, stay connected order, I think, through October 14th, 2021. And COVID was the number one cause of death in Arizona. It's not this case in every state, but it is in ours. And we will just pause to recognize all of the families that are impacted by losing loved ones. We know that you all are, as healthcare workers and our workforce, are right alongside those of us who work in this public health space. Thank you for doing this every day. We are so appreciative of you and honored that we're by your side, helping our communities and most importantly, getting vaccines in their arms, because that is what's going to get us all back to normal. And it gives us a lot of comfort knowing that we all have this ability to really start ending this. So please stay in it. We know things are really hard right now. We know you're short-staffed. We are all very tired too, but there is a light at the end of the tunnel, because soon we're going to start vaccinating our kids, those snotty, huggy, kissy kids. So we'll talk about kids, but Mrna, let's start with booster doses. Lots of news about that since last time we all met. So one thing that's come up is, what is the darn difference between a third dose, an additional dose, and a booster dose? So go over that with us.
Okay, so an additional dose is that third dose we've been talking about. And that's really for those folks who are immunocompromised. We're talking about those who are currently on cancer treatment. We're talking about organ transplant, those that are truly at a higher risk because their immune systems didn't respond incredibly well to their primary series of the vaccine. A booster dose is a true booster dose. It's something you give after your primary series is complete. And actually it just boosts that immune response that's been waning over the last couple of months.
And we're going to talk about who should get it and who may, but just to call it out, I love whoever found this picture for this slide, because we all need to be urging pregnant people to get vaccinated. The CDC has updated their recommendations on this. Our OBs, my own brother was convinced by his wife's OB to get vaccinated against COVID-19, as was she. So OBs have we are really hitting those pregnant people hard with these messages right now. So, okay. So third dose, immunocompromised. Who is immunocompromised?
So it's anyone 12 years of age and older, and anyone who's received either Janssen or Pfizer or Mrna, and it's anybody who's just severely immunocompromised. Again, organ transplant. It could be cancer treatment, and you don't need a doctor's note. So this is self-reported. So anyone who considers themselves immunocompromised can actually receive that third dose. You're going to give it 28 days after your last dose. And it can be actually any manufacturer you want. You can get that third dose of Pfizer, Mrna, or Janssen & Janssen. It doesn't have to be, your third dose doesn't have to be the same vaccine type that you received initially.
So if you're a provider, make sure you check with your providers about whether they want to screen for different conditions. But I think for events that Mrna does or her nursing program, a patient comes in and says, I'm immunocompromised, they're just getting that dose. So if
right.
From a private office, make sure you check with your providers to see what they want to do with this. This, like Mrna just said, is different than a booster dose. These people need that third dose in order to have that complete series. So.
And we're at community events trying to make it easy as possible by not making folks get prescriptions or notes from doctors.
Yeah. And is there a, Jay's asking in the chat, is the third dose and the boosters the same amount? But we will get to that. Stay tuned.
We will get to that because it depends on the vaccine. Okay. So everyone gets a booster now. There are recommendations for all 3 vaccines currently on the market. The people who should get a booster are anyone 65 years of age and older, anyone 18 years of age or living in a long-term care facility or any congregate type housing facility, 50 to 64 with certain underlying conditions. And it also, anyone who received 1 dose of J&J should get a booster. Folks who may get a booster are those 18 to 49 with any underlying medical conditions. And those are pretty broadly defined. Anywhere from overweight to asthma, diabetes. I mean, there's a plethora of those underlying medical conditions. And then anybody aged 18 to 64 who feel that they are at increased risk because of their occupational or institutional setting. Again, not asking for proof. We're not asking for people to say where they work or what their underlying medical condition is. If they come in and say, I want a booster, I need a booster, go ahead and administer that booster.
So boosters for mRNA vaccines.
Right, so the boosters for the mRNA vaccine, 6 months after your last COVID-19 vaccine. So whichever mRNA vaccine you received, whether it be Moderna or Pfizer, it's 6 months after that last dose. If you have received Moderna and Pfizer or J&J, you can get whichever vaccine you want.
So, and I know we've heard from a lot of our private offices that when they give that second dose now, they are saying to the patient, okay, today is January 15th, 6 months from now, it's going to be June 15th. That's when you're going to be due, and talking about this booster day. Just so you're aware, for those who are doing mass vaccinations, like the county health department, and really doing that, you know, acting as that safety net, we are still focused on primary series vaccines. There's still a lot of Arizonans out there who have not gotten their first doses. So, or had their initial series completion. So if a patient were to come into Mrna's clinic and say, I want a booster dose, of course they would not be turned away. However, they are not focusing on booster doses. So for those of you who have patient populations with a lot of immunocompromising conditions, we hope that you do think about calling all of your folks in, because they're not going to be called back in otherwise. So they'll get called back in for their second doses, but not their booster. It's just not where we're putting resources right now. Moderna dose booster is?
Moderna, this is really important. This is only half of the dose. So it's 0.25. I know that a lot of you have syringes that don't read 0.25, so do your best. And with Mrna, you can only puncture the vial 20 times. So this is where you want to come up with some technique to keep count, because the Mrna vial is only good for 12 hours and 20 punctures once you puncture it.
Okay. How are you guys keeping track of the 20?
So what we're keeping track of is we're going ahead and we're using Ziploc baggies. We're using high-end technique here. We're using a Ziploc baggie. We're putting 20 syringes in with the vial. And then if we give a lot of boosters or if we give full doses, it's either when the vial is empty or when those 20 syringes are all used up. Either or, then we know it's time to open a new one.
It's good. Hey, it works, right?
Yeah. You know what? Don't worry about anything high tech. Just think about what is easiest to get, and what meets your needs. And seems to be working.
Cool. So J&J. So for mRNA boosters, if you're 18 and over and you want a booster, you can get a booster 6 months after. Pfizer booster is the full dose. Moderna booster is a half dose. J&J, so that's kind of the same. J&J boosters are different.
J&J boosters are different. They're 2 months after your last J&J dose. You may either receive Moderna, Pfizer, or J&J for your booster. It doesn't matter. Patients can choose their own. And again, your booster day is 2 months after your last COVID-19 vaccine.
So and they can get either one 2 months after.
Correct.
Yep. Mixing and matching.
Booster mix and match. I think this is going to make our lives a little bit easier.
Yes.
Hopefully. We're thinking it is as well. So it's regardless of brand, people can choose whichever one they want. You know that there's a lot of information out there and that folks are able to get a lot more information to make a decision on which booster dose they want. Again, if you don't carry all the vaccines and they want a vaccine you don't have, there's more than, they can go to any pharmacy, any other pop-up or community event and find the one that they want.
Yeah. And they can get other vaccines.
And they can get other vaccines at the same time. So all vaccines may be given with other vaccines regardless of any timing. I think the number one question I've gotten this entire flu season is, can they be co-administered with flu? They absolutely can be co-administered with flu. Just you give one in one arm and one in the other. And this also goes with peds offices. If you have, you know, those 12-year-olds come in and they need to be caught up, you can go ahead and give the vaccine, the COVID vaccine, along with their second HPV.
I was at an event last week and a guy said, my doctor just keeps calling me about that shingles vaccine. Can I just get that here? And I'm like, no, but go to the doctor, get the shingles vaccine. So the only reason why you can't get it here is because we didn't have any of it, but that's why we want them in the office. And you're giving flu, right? You're giving flu and COVID together.
Yes, we're giving flu and COVID together. And actually we have some events where we're giving all of the pediatric vaccines along with COVID.
Right. So I'm going to roll through the chat a little bit. So someone said, sorry, I missed that. Did you say good for 12 hours? I think this is about Mrna.
Yes, Mrna is now good for 12 hours once you puncture the vial.
And another person had asked, can you get the half dose and the full dose out of that same vial?
Yes, you can. You can use the same vial.
Okay. Do patients get antibody tests before the third dose or booster?
No.
No. Nobody. Yeah.
Nobody does. No.
Annette, thank you. That looks awesome. So people are putting in their labels and things that they're doing to make sure that you don't get more than 20 out of that Mrna, 20 punctures out of that Mrna. I can tell what it was. Yeah. All right. And Jen is doing a little billing clarification. So the billing code for Mrna half dose will be different. Jen, do you want to unmute and talk about that for a second? Because I think that just Mrna boosters in general are pretty new to folks right now.
Yeah, you bet. So, you know, that's been one of the questions. How do they document a half dose versus a full dose in an EHR or an ASIIS? There are completely different billing codes for the booster dose for Mrna. So when you draw up that 0.25, you bill that under a different vaccine code and a different admin code than you do the 0.5 or whatever it is ordinarily. So that's where the difference is. And that will automatically populate your EHR, the patient records, and it'll populate ASIIS as that half dose booster.
Great. And a reminder that we can co-administer our vaccines. There's no wait times anymore between vaccines. So, I mean, there are with the live virus vaccines and all, you know, all of what you're used to, but with this COVID vaccine, you don't have to wait 2 weeks. You can give that vaccine with everything. That changed. When did that change?
That changed. I have no recollection of time or dates anymore, but when
we went down to age 12.
It was when we went down to age 12.
Which was May 10th. I remember that day. It's my birthday.
Oh, okay.
So that's when 12-year-olds could get it. We will make sure to send out information about those billing codes. We'll put it when we send the recording for this, we'll make sure that all of the most up-to-date information about billings on that link too. So if an individual tests positive for COVID, there is no wait time until they get vaccinated. Once they are out of quarantine, out of isolation, they can go ahead and get vaccinated. So, and that's the same for initial and for booster doses.
Yep.
Anybody else you can unmute any questions on boosters before we do a quick overview of kids? You can put it in the chat or unmute yourselves. All right, kids, we aren't going to talk a ton about kids because you should only be immunizing kids who are age 12 and over right now. But Mrna, give us the lowdown on our 5 to 11-year-olds.
Okay, so I'm looking into the future. So on October 26th, the FDA Advisory Committee recommended that children 5 through 11 receive Pfizer. The ACIP will meet November 2nd and 3rd, and you remember the ACIP is the advisory committee that advises the CDC. And then shortly after that, the CDC director will make the recommendation. So the earliest we will be immunizing children will be late in the day on November 3rd, most likely starting November 4th. Pre-orders were placed on October 20th, 22nd, and 24th. So physicians could pre-order. How this system worked was they pre-ordered through their county health departments, and their county health departments allocated vaccine. The minimum order was 300 doses. Now, I'm not sure, but some health departments might have allowed physicians to order 100 doses, and then those would go through the county health department. Any physician who ordered 300 doses or anything in increments of 300, the vaccine will be delivered just like you get VFC vaccine. It'll show up through FedEx, UPS. It will come with an ancillary kit. It will come with a vaccine. After the initial rollout, we're hoping sometime the week of either the 8th or the 15th that you will be able to directly order this vaccine through ASIIS, and you'll be able to order a minimum of 100 doses.
And this is going to be different for these kids.
These are going to be different. I think this will make our lives a little easier. I'm hoping is that for the current 12 and older vaccine, it's a purple top. For our kiddos 5 through 11, it's going to be an orange top. The storage and handling is going to be different. For the orange top, which is for, we're calling a little Pfizer, it is going to, this vaccine can be stored in the refrigerator for up to 10 weeks. It will be delivered to you in an ultra cold shipper at that ultra cold freezer temperature. But once you receive it, unpack it, inventory it, make sure it matches what you were requested. Then it will go into your refrigerator, 36 to 46 degrees, just like all your other vaccines, and will go in there for up to 10 weeks. This vaccine will come with its own diluent, and actually administer only 0.2 of this vaccine. So there are some differences, but again, please remember, a lot of you who ordered vaccine are going to be getting it next week. It may be on the 31st or the 1st. Please put it in your refrigerator, label the date that you put it in there so that you know when your 10 weeks is up, and please do not administer until we get the CDC director, Dr. Walensky, saying it's a go. I know a lot of us have been really excited for this moment because most of us are kiddos nurses and baby MAs and doctors, and we just know that by immunizing these kids, we're getting close to ending this, and we're going to make our kids so much safer in school. But please wait until the CDC announces that it's a go.
So what do they put a sticker on it saying do not administer, do not use, or what's the practical thing that we do? Throw it in the back of the fridge?
The practical thing that we do is we usually put it in a paper bag with a label that says do not use. And we label it. So we will label it, we're going to label it Little Pfizer, just the nickname we've given it. We're going to put it in a bag. We're going to put it, and it's do not use.
Okay. So we have Jay, a couple things in the chat. So J&J is this, what's different, they're all different in their own way, right? With J&J, your booster is 2 months later, which is different than the others, which are 6 months later. With Mrna, the booster is 0.25 dose, which is different than the other two that have full doses. There's no difference in that. And with Pfizer, what's different is the packaging and the dosage for little kids versus bigger kids and our biggest kids, adults. All of this will be subject to change though when it comes to those pediatric things. So,
and actually the schedule for the 5 through 11 will be a 2-dose series. So when they did their clinical trials, they did it on the same schedule as you do the 12 plus. So it'll be 2 doses separated by 21 days.
There's a question in there. We are going to really dig deep into kids on November 11th at 12. So once it's cleared through ASIP and CDC, we'll give all of those pediatric practices like a week to start doing things, learning things, and have some questions. And then we will all get together from 12 to 1 and review all of this kids stuff. And then it'll all be, more firm because CDC will have met. So I do want to make sure we give time for JJ, but just going through before, I know you can't stay on at 1. So how are you managing the 0.25 dose transfer to ASIIS? How is everyone managing the 0.25 dose transfer to ASIIS?
This is Jen. I can jump in on this one. If you use that correct code for the admin code for Moderna at the 0.25, it will automatically populate ASIIS as a 0.25 and decrement that dose correctly.
Okay.
In theory.
In theory, yes.
It'll take a while to work out the bumps, as you all know.
Mrna, someone's asking, Annette's asking, will the transfers of the 5 to 11-year-old vaccine be just as quick as in the past?
What do you mean transfer?
Like transfers, like the delivery of it?
Yes. Yeah. We understand that if it's shipping on the 31st, it will be to your offices by the 1st. So if it's coming, the vaccine that's coming directly from Pfizer will be shipped within 24 hours.
Mrna. This is Annette.
Uh-huh.
So then if where we allocated the vaccine is if we request a transfer from that facility, that's what I'm asking. So like, you know, because we just allocated all 300 doses to one facility because they have a better storage system. It's bigger than ours. But if we needed, say, I'm guessing that the minimum amount of transfer vaccine we could get is 100, right? I'm guessing, are they coming in 100, like a box of 100, or?
I don't know how it's coming.
Okay.
We bought some little boxes that would allow us to distribute less than what is packaged. I think it all depends on ASIIS, because once you put in an ASIIS transfer, ADHS needs to approve it before it populates the provider you're transferring it to's inventory so they can accept it. We've covered that it takes about 24 hours for the VFC folks and ASIIS folks to approve that transfer.
Okay, so it's not like it's going to be delayed, you know, 2-3 days as far as we know, because the transfers in the past have been like 24 hours or something.
I think we're still going on 24 hours because that's what we're routinely seeing. And that's what we saw early on, but that may be a really good question to ask of ADHS, the VFC program.
And you said you bought special boxes.
You know what? Let me have someone, we've got them from a lab company or something, and they actually hold, Jennifer Tinney actually took a picture of them. And they actually will.
I do, I'm trying to find it.
They will actually hold the little Pfizer vials and keep them from jostling around.
Yeah, Jennifer, if you don't mind sharing that, that would be great as a resource.
Because I think what a lot of physicians were concerned about, and a lot of offices were concerned about, was that when you think about pediatric vaccines, when you think about 300, all I can picture is, 300 doses of Tdap or 300 doses of a pre-filled vaccine that take up a lot of space. This vaccine takes up very little space.
Right. So our last question, and again, Jen Tinney will stay on at 1 and keep the line open for 15 minutes or so and answer whatever she can answer, and also billing questions. But Dr. Barnes-Clark is asking, and I haven't seen that name in a while, so it makes me happy to see all these pediatricians getting ready to vaccinate. Should we use half of our allotment and then save half? And the answer to that is no. We use all of it that you can, whatever you get. We have no reason to believe right now that there's going to be a shortage. You should be able to get your second doses in 21 days, right, Mrna?
Correct. We have seen no shortage of vaccine. Neither Moderna nor Pfizer. I know all of you saw there was a little bit of Janssen a while back, but now that's not a problem. There's absolutely no shortage of vaccine anywhere.
Yeah, in our country.
In our country.
Yeah. So, okay. Well, we are excited that we're getting towards kids. We really do believe that you are the way out of this, because a lot of our kids are spread COVID as well. So, and also that having this approach of having families go into their medical home and be talked to by their child's physician or nurse practitioner is going to go a long way in reducing hesitancy. So I do, and we've answered lots of questions. So I'd love to introduce JJ Rico now. Well, I think that as we've gotten ready for kids, a lot of us are kind of having flashbacks of, you know, giant pods with thousands of people pulling up. We don't think that it's going to look exactly like that. But when that approach was being used, many of us were commenting and talking about how that approach did limit access. You know, it was needed at the time, but limited access to vaccine by lots of different groups. JJ is the CEO for the Arizona Center for Disability Law and talks and thinks all day about making sure that healthcare services are accessible to all Arizonans. So we're really excited to have you, JJ. And I'm going to bring up, if you want to unmute yourself, and I'll bring up your thing for you here. Let me.
Great. And I also put it in the chat in case folks aren't in front of their computers. You can pull it off of the chat. And so thank you. First, I want to thank every one of you for what you do out there, both professionally as someone who advocates for people with disabilities, and then also as a parent. And one of my children is a 14-year-old with cerebral palsy and epilepsy. So again, for the providers in the room, for all of you who are trying to make this a reality and have been dealing with this and making sure the vaccine and COVID safety are out there and a priority. Again, big thank you from me on both hats that I wear. So what's before you is just a tip sheet that we created, and it did. Obviously, COVID has changed over time in terms of where and how we're administering and where we're administering the vaccination, and we're just on the cusp of 5 to 11, which makes me really excited. And these accommodations and these tips apply to all of those scenarios, apply to all the ages, apply to sites that are as small as an individual's doctor's office all the way to Cardinal Stadium way back when. And so most definitely want you to kind of use this, share this, copy it, give it to your frontline staff. If your frontline staff, have this next to your phone before you answer the phone and field these questions. And so I know I have limited time, so I'm going to really kind of emphasize two areas that I think, even if you're doing the best access and you're accommodating all of your patients and people with disabilities, always good to kind of refresh. And it's a perfect time to do that right now because we're about to have this new population, right? We're going to have 5 to 11-year-olds. They're not going to be the ones calling your office. If they are, that's pretty cool. But it's going to be their parents. And for those of you who've worked with parents like myself, there's going to be a lot of questions. Maybe even more so than the 12 group, and probably even more so than the adult group. So kind of making time in your schedules and how to field those calls. So the tip for this section is, what is your front-facing information saying? So when I say front-facing, I'm describing your website. Do you have signs on your door? If people are coming into your office, do you have live people answering phones, or are you providing phone numbers? So it's a good time to even, after this session, is to call yourself and see, what does your message sound like? Does it need to be updated? Is it accessible? Is it overly complicated? You know, so people with disabilities and people without disabilities really benefit from clear, concise information that gives them good direction, a good plan. And that's really where we're seeing a lot of the hesitancy come from the disability community, is lack of access, not necessarily always the hesitancy for the fear of the vaccine or the unknown. I'm not going to say that doesn't exist, but there's a recent CDC study that's saying it's largely this access barriers that is causing the hesitancy, not wanting to go out or not knowing what they're going to encounter. So making sure your website clearly describes what service you're providing, who they can call, and how they can request accommodations. When we think back when the state rolled out these big sites, really, and from our perspective, where the state fell short was in not allowing, but giving someone a contact number for requesting accommodations or to ask questions about accommodations. So I think, again, if your site allows that, excellent. But in talking, I've done about 5 or 6 of these. A lot of folks didn't have any information about reasonable accommodations. And someone had a great simple question where they said, is it as simple as just putting on there reasonable accommodations available, call this number? And I said, yes, it's not complicated. You know, it's really just that phrase and a phone number or a link. Now, we were part of hosting a disability specific event at Ability 360 Center in Phoenix. And what we feel made our event so successful was we provided that phone number and then they were called back. So again, you can have a great message system, you can have a great announcement on your website, but if you don't have someone calling back and ensuring that individual that they're going to receive an accommodation, you're falling a little short, right? So you're saying we have it, call this number, but no one calls them back. And as a lawyer, I can tell you that's the number one complaint about lawyers. So this is not just a medical professional, you know, kind of saying, oh, you guys are not calling people back. My field, that's our number one complaint against lawyers is we don't call people back. So make sure that you know, you're okay, you got a survey in there. Good little survey question. Go for it.
I'm curious whether if you, while you guys answer that, to see, do you have list a phone number where people should call for special accommodations? And then when we were looking through this, JJ, we were curious, what is a screen reading technology? And like, how would a practice know whether their website's compliant with that?
Great. So as those numbers come through, let's address the website. So there are, again, this is not me. Remember, I just disclosed I'm an attorney. So it's IT people that know this information. And so there is certain code that's embedded into websites that allow for a screen reader. And so a screen reader software can be something called JAWS. So essentially what it does, and you might have this even on your phone, if you go into the accessibility features of your phone, if you have an iPhone, you can choose this and it will actually read to you what's on the screen of your iPhone. And the same thing holds true for websites. And so I would, if you have IT providers, contractors, people who work for, if you're part of the state, I'm sure there's an IT department. We contract with a private IT firm and they can test. There is guidance on the second page of this guide that you have in front of you that gives you a link to that information in case you want to provide that to your IT people. A practical way of testing this is if you do have any consumers, clients, patients that are users of screen reader, they can go and test and tell you. Now, what traditionally happens is the front page is accessible. Like you can put something out there and the person can read what's on the screen, but then the links are not properly coded. And so the person can't navigate the page. So for example, you might be able to read all the text that's on here, but if I have a hyperlink that's not properly coded, the person kind of reaches a dead end. So it's important not to, you know, to not only test the content, but also your links to make sure they can navigate. Now, in the interest of time, we're talking about next week, right? Rolling this out. So if you're like, my IT person can't get to it, we don't know. So that's where the old fashioned, let's provide a phone number and have someone answering the phones and getting back to them is an alternative. It doesn't have to, you know, again, try to make sure that you're doing the best thing you can do in the interest of time, and then obviously improving and updating as you can. But I know our IT guys right now, just with everything else, computers and other services are delayed. So looking at the survey results, you know, we have about 48% of folks responding that they do have a phone number people can ask for accommodations, either on their website or an event flyer. About 22% no, and then there's about 30% that said, I don't know. So I think that's a great thing for those who don't know to go back and ask, because again, people are going to start calling. And I can tell you as a parent, right now my child actually broke his foot, so he's using a wheelchair. And so we're looking for, and this brings me to the next front facing thing, is all the signage in the world that points us where do we park and how do we get from the parking lot inside. And so, you know, if you don't know if you have a phone number or you currently aren't providing that service, then make sure that if someone's showing up at your site, that you've done a little quick survey for parking and then access. And access can be things that, again, making sure there's designated parking, but also plenty of signs. And signs can be as simple as arrows. And I'm telling you, people with disabilities rely on the universal symbol where they can park, but the next thing they're going to look for is a sign that says, go this direction. and walk that yourselves to make sure you're not pointing them to, yes, a sidewalk where they can access, but there's no curb cut. Or if there is a curb cut, is the parking closest to that curb cut? So again, these are for folks who are, you're creating these pop-up sites. Even those of you who have dedicated office that are going to be administering these things, please look at that. Now, I did learn from Rebecca and others that some of you may not be providing the vaccine yourself, but be by directing your patients to a particular other location. I would ask that, you know, as a best practice tip is for you to still go out there so you can help your patients know that, okay, yes, we're not going to have it, but let's say Phoenix Children's Hospital is going to host an event. And I've gone there and there's plenty of parking. Look for the signs. You're going to be able to get there and, you know, it's accessible. But if you don't do it, you're going to be asked those questions and you're going to be left with guessing. And that could turn someone away, just not knowing, and especially for various disabilities, right? If you have potentially a child with autism that has sensory issues, if you don't know the sensory accommodations that are built into a location, whether there's a quiet room, an ability to turn down lights, ability to schedule their appointment maybe early in the morning with less crowds or late in the afternoon, that person may be turned away just by not knowing that their child's going to receive an accommodation. So always good, even if you're not you individually are not administering the vaccine, always good to know maybe where you're directing them to, and then working with your partners in this to make sure that your patients receive accommodations. You might be great at it every time they come into your office, but now if you're directing them somewhere else, always a good tip to make sure you know where you're pointing them. I'll pause for a second and see if there's any questions or any comments in the chat. Feel free
to unmute yourselves or go in the chat. I'd be curious too for and talking with a lot of our offices, it sounds like people don't know what they don't know. So it's not until that patient comes in and has a particular need that they realize, oh, wow, you know, we were really not accessible to that family. You know, that took that family a lot just to get here. So if you have any of those tips or things that experiences you can share, we'd love to hear them too.
Yeah. So, you know, I think a tip or a best practice is always to start with, you know, how can we help you or how can we help your child, you know, if we're talking about children, and let them kind of share. Now that they may share, oh, I need, you know, 10 different things, and you may not know whether you can do any of those. So the next best practice is not to just say no, or no, we never do that, because that's the number one call that I used to get when I'm practicing was we were just told no, they said we don't do that, and they said go somewhere else. Or they said, you know, call, you know, we don't provide that, you need to bring your own interpreter. We'll get to kind of the effective communication issue. So the best practice or tip is just how can I help you, kind of explore that. And then if you don't have an answer right then, is just to say, let me get back to you, and obviously call them back, and then brainstorm with your office of, okay, we have, let's think through a scenario here. We have a young child who is in a wheelchair, and also maybe my child, for example, who's new in a wheelchair, and for some reason he couldn't, you know, transfer out of his wheelchair and had to stay in the car. Now, maybe your site was just set up for in-office vaccinations, but this could be an opportunity where you evaluate, can we make a modification to our practice to provide that shot in the car, either due to a permanent disability or a temporary disability, exploring those accommodations. An issue that came through slightly COVID related, but also showing that, you know, sometimes you got to modify those policies, was an issue related to CVS used to bring out medications to a caller of ours as an accommodation during COVID because they're immune compromised. And once kind of all the issues got lifted and, hey, yes, you can come in and it's safer, all of, you know, the parents still needed that. I mean, the child could still be exposed. So in there, we were asking CVS to still continue that accommodation. So again, start with that, how can I help you? Explore alternatives. It doesn't always have to be exactly what the person asks, but it's always good to explain, like, we're not able to do exactly that, but what we can do is this. And then ultimately, if there's no way that you can do it, then it's an exploration of who might be able to do it. And that's where you have to use your partnerships and your knowledge of what else is available. If this child would benefit from a homebound delivery, Will this person benefit maybe from a smaller location because, you know, it's not a big event with music playing and, you know, kind of trying to do a celebration type vaccination event. So again, it's always good. And I know your goal is to get as many people vaccinated as possible. And I think for people with disabilities, they just want to know that they're going to have access to your location, and then how exactly can they get the vaccine for their child or for themselves. So I will talk a little bit about effective communication. So when I mention effective communication, I'm talking about a couple areas. One, let's start with plain language. Plain language is basically a more direct way of writing at a lower level. And this not only benefits people with disabilities, but our community at large. Unfortunately, our literacy rates are going down, and I'm not sure if it's still 6th grade. It might be lower than 6th grade now. So writing the information, at least on where to go and how to get there, and what's being provided in plain language. Now I know COVID information or vaccine information is high level stuff. If there's any way to translate some of that into plain language, that would be excellent. Ways that maybe parents could even utilize that information, not only to educate themselves, but possibly then to share with their children what's about to happen, or why they're receiving this shot. I mean, I think there's a lot of shotted versions, period, but there's a lot of media and press about, obviously, the COVID vaccination. So the child may be getting mixed information or may not be hearing exactly what they need to hear. And so delivering that information effectively in plain language would help the parent and also the child. The last thing before I go up into American Sign Language interpretation, or for those who are hard of hearing, I would just advocate as a parent that spending enough time with the parent to address questions, and then also to give some practical tips that that I think will go a long way. Again, just personally speaking, I think that we as parents, what we needed from our practitioners, which we received, was some problem solving tips. Now, I'll tell you what happened for our child. He's 14. As I said, he had epilepsy. And as we know, one of the side effects could be increased fever as a result of the shot. And so sure enough, the first time around, we didn't take any proactive measures. We administered the first dose, got the first dose administered, and he spiked a fever and had multiple seizures that evening. Now, just be full disclosure, it concerned me and my wife of whether or not we should expose him to the second dose following that increased seizure activity. But what we did was then reach out to our practitioners and got some tips. And I keep using tips also because you all are tips. My bad joke for the day. But what we did was we got a fever reducer and also slight increase in the seizure medications, and administered both of those prior to and after the second dose, and no seizure activity whatsoever. Now, again, that's a great positive story. I know that some parents may not feel that's assurance enough, but I can tell you it helped us have peace of mind and also get our son fully covered with the 2 doses that were recommended at the time. So I think that was a doctor taking some additional time. And I know your time is, valuable and precious, but really as a parent of a child with disability, we have been advocating for our child from day one, even more so than, the typical children that are out there, because, we're asking a lot of questions. What does this mean? What's the future, et cetera? So a little bit more question answering, those kind of things, making your appointments conducive to the answering of questions plus the vaccine. Our pediatrician does a great job of, every time a vaccine is due, of spending a little extra time, because he knows kind of the questions we're going to ask, but he also knows what the benefits of the vaccine are. And so he does a real nice interplay back and forth with us that gets us ultimately a vaccine for the day, maybe not all 3, but maybe 1. So again, whatever you need to utilize, and you probably have already done this with some of your patients, keep doing that. And with the COVID vaccine, you might just have to do a little more. Now, let me talk about American Sign Language interpretation. This is a big issue for the disability community. We have a whole program dedicated to this. Unfortunately, medical professionals have had challenges understanding their legal obligations to provide American Sign Language interpretation. So I'm just going to back up real quick and say, English and American Sign Language are not the same language. There are two different languages. So if someone first language is American Sign Language, traditionally their secondary language is English, but their English abilities aren't to the level that even we were talking about before. So if you ever see someone write whose first language is ASL, second is English, their writing of English would look like they may not know English, but it's a second language. It would be like me attempting to write Spanish. It'd be broken, it would have some words here, you'd probably get what I'm saying, but it really wouldn't be effectively relaying the information. So a lot of times what we see is, well, we'll write notes, you know, or we'll give them a flyer that says, here's the information about COVID, and we've done our job. But as I was just saying about this inner exchange between parent and child and parent and doctor, that's the effective solution is an American Sign Language interpreter. Now, the question popping in your head, probably two questions. One, it's always cost, right? It's like, oh, well, how much does that cost? It varies. What I would do is reach out to the Arizona Commission for the Deaf of Hard of Hearing, who's a great resource. They're listed on this page as well. And they also have a list of all the interpreters. They're actually the agency who licenses interpreters. So you can ask those questions, try to schedule. The second is, do I have to pay for it? And the answer is yes. And then the third question is, do I have to provide it every single time, or how would I know? And this goes back to the first suggestion of making sure you have an accommodations form, question, phone number, so that someone can request that. Now, fourth question might be, well, what if somebody just shows up? What if they just show up and they say, hey, I need an interpreter. They write on a note, American Sign Language interpreter, question mark. Well, there are a couple tips here. One, obviously, you can write some brief notes just to say, let's say in this scenario that I've just presented, you don't have a sign language interpreter on site. You say, no, we do not have one. Do you need one for information about COVID? If they say yes, then you could answer, well, we will schedule one. Can you come back? You know, and then if they say yes, great. You schedule one, you contact them, get it in, bring them back in, problem solved. The other solution that you can start planning on now, if you don't already do this, is to work with or establish video remote interpreting. And that works on a laptop, on a tablet, or on a computer, where essentially you're doing what we're doing today. The person who is deaf sees a person on a screen and they're signing American Sign Language to them. And then, you know, if you're saying the COVID vaccine has these side effects, the interpreter is signing that to the person who speaks American Sign Language. They sign back to the interpreter saying, oh, thank you for the information. I have one more question. They relay that verbally to you, so you understand what they're saying, and it goes back and forth. Now, if you do provide video remote interpreting, you make sure that the screen you're using is large enough to see, because as you can imagine, using your phone, even though probably many of us do FaceTime or other video chats, that's good for someone who is hearing and can hear what your friend is saying and may not necessarily have to rely on seeing their friend on the other side. I'm just using a friend example. But think about someone who's trying to also see someone's hand gestures on the screen and also their body motions and inflection, because it is a full body language. So not just the hands, but also the gestures sometimes become larger or more pronounced depending on the emphasis that the speaker is providing or relaying. So a phone is not a best solution. A better solution would be a large tablet. But if you're going to use any of those devices, make sure you have a strong internet signal. Because just as I was seeing in the chat as we were starting, some people were saying, I don't have a great connection, I can't hear too well, you're breaking up, I'm going to shut off my video. And that's what happens a lot of times when medical professionals are using video remote interpreting, is that the person is breaking up so much that it's just not effectively relaying that video. So you can provide video remote interpreting as an alternative, but just make sure it's working. And that's the other thing that we used to see. We don't see it as much anymore because it's been around a while, but people saying, yeah, I think we have that, but I don't know how it works. So if you are going to use video remote interpreting, make sure you know how it works. So I'm going to pause there because I just gave you a lot of information really fast, and just to see if there's any questions or comments.
And feel free to put it in the chat or unmute yourself. We still have a few minutes. I am going to launch a poll here too, just to see if anyone is thinking, well, I do think that my office can improve in this way, or maybe this is one thing that we could do differently. And it doesn't have to be next week. We know we're all under a lot of pressure, but as soon as we can. And I'm wondering too, just since we were talking about ASL, we've had a lot of comments about maybe a hearing child who has parents that are deaf or hard of hearing, and the child speaks English, but the parents speak ASL and the child's probably bilingual. How does that?
Yeah, that's a great question. So we see that a lot. So one, you do have an obligation to provide sign language interpretation for the parents who are ASL, who speak ASL and who are deaf. To use of the child, even if they're bilingual, is, hate to say it, but I'll just be direct, is illegal. There's a lot of bad cases in Department of Justice decisions about many things, not just healthcare offices, but others using children or family members. So that's not permissible under the law. They can, obviously communicate to their parents, those kind of things if they need to, but not as a substitute for one of these effective communication tips that I just reminded you all of, and that's in the form. So yeah, that happens. We do have children who are hearing but communicate with their parents through American Sign Language, but your obligation is to provide that parent with ASL if that's what they need for effective communication, or one of those other accommodations that I suggested. So I know I only have like 1 minute, but I'm interested in this poll just to see if I can reduce anything here. I'll run through these. So hosting and training, we're available. So if you liked what I said or you thought it would be helpful, let me know. I'll put my contact information in the chat. You can reach out. Our agency would be happy to do it. We have a dedicated CDC grant to accommodate to achieve that goal, so it's at no cost. ADA van accessibility is only 1 out of 13, but that's easy to do even if your current location doesn't have that. If you know you're hosting an event or people are coming, you can always rope those off, mark those off if you have control of your parking lot. I know sometimes you host events where you may not have that control, but it might be worthwhile before you're contracting or rolling out an event to see if you can identify more accessible space. Department of Justice has a great guide that gives you all the measurements and all those things to make more van accessible parking. You can lay that out in a temporary way with rope and other things. Sensory items, a lot of you I know get some money related to vaccine access or vaccine equity. Put it towards some stress balls that say get vaxxed or something like that. And, great way to kind of promote things and pass them out. And a lot of people benefit from that. I don't know who looks forward to getting a shot in their arm. So I think this would just be a great thing to really encourage and maybe market this. Photos, graphics, again, this is as simple as printing it out on your computer, printer, and making photocopies. These don't have to be fancy, laminated, metal, any of those things, just big arrows and big direction signs, etc. Communications for the deaf and hard of hearing, that is available and free on the Arizona Commission for Deaf and Hard of Hearing sites. And that link is the last one under helpful resources. So if you go to that site, you're going to find that for free. You can print those out. If you need more, reach out to them. Betty McIntyre is their outreach person. She's amazing, there to help you. If you do need clear masks, they will also be a great resource for pointing you in that direction. On the website, again, talk to your IT people. There is a link here on the web contest access accessibility guidelines. They're going to be able to read that language. Talking about foreign languages, any of that IT code, any of that information, foreign language to me. That's why we give you that tip and also that link so that you can share that with your folks. And for the 5 of 13 that says you do all those things, congratulations. Again, we're not here to say anyone's doing anything wrong. We're here just to give you the best tips to make your offices, your events as successful as possible and are inclusive of people with disabilities. So I think I've fulfilled my time. I appreciate the platform to do so, but happy to do this again, either for the tips group or anyone else. So I'll put my email in the chat if any of you'd like to talk more or bring me out to any of your events. But good luck. This is really exciting for me. I've got that behind the scenes of when these things are rolled out, and hearing about Orange Cap and other things are kind of feel like I'm in the know now. So I really appreciate it. And thank you for the time, Rebecca.
Oh yeah. And thank you for everything that you've been doing for our kids and for our adults who we want just as badly as you to access all of our healthcare services. So we're really excited at TAPI that we've like renewed these relationships with JJ and all of his friends who've been advocating for the folks who are members of their community for so long. And one thing to as we've been kind of digging in and learning a little bit more, which was a big aha or maybe slap a little bit in the face, is that their community has grown significantly during the COVID pandemic. So it is the only group that we look at disparities that is ever changing and we can all become a part of at any point in time. So there are a lot more, I think, discussions that we'll be having about improving accessibility. So thanks for everything you do. Yeah. And we don't mind your dad jokes every now and then, I guess. Good to have one on here.
I said bad jokes, but they are dad jokes too. You know, my boys would say they're probably dad and bad jokes. So thank you.
Yeah. So we are out of time. Jen will stay on the line for 15 minutes along with some other TAPI folks. Please make sure that you take that survey this time. On November 11th, we're going to be back at noon. We know it is technically a day off, but it's not for many of us, but not for anyone who's in practice. So we figured, well, all of the docs will be working anyway, as will the MAs. It seems like as good a day as any for us to have our tip session. So we will be back then, and thank you all so much for everything that you do.
Thank you, Rebecca, and I know you guys have to hop off. I am here. I am a cartoon today. My camera is not working. It keeps giving me an error, but I am behind the cartoon with the giant syringe that was left over from our last flu H1N1 pandemic. So anybody have any questions? We covered a ton of information today.
Jen, there were some things that I don't know if you guys got to it, but to review, I wonder if we review for folks who haven't gotten vaccine yet, the regular system of a week before you get your ancillary kits, is that all happening? And so I give that to you and then I go to my one. Bye guys.
Bye everyone.
Bye,
thank you. See you in 2 weeks.
Bye. Yes, once you put your order into ASIIS, and I understand that there is a way in there to indicate whether or not you're doing primarily adult, primarily pediatric, or a mix of both. And then you will receive the ancillary kit, which has all of the supplies that you need in there. It's going to have the syringes, it's got, it has the needles, the syringes, the alcohol pads, the vaccine cards, the face shields, and 4 surgical masks for your staff to be able to give the vaccine. So that kit will come out ahead, but you might want to indicate if you think you're going to have more pediatric or more adult. They do a mix of both sizes in all of the kits, but you can also get a half and half that'll mix both of them kind of at that 50%. So you just might want to gauge if you think you're going to have more kids or more adults and order accordingly. But based on the pediatric doses that are shipping, since they're shipping in lots of 300, you're actually going to end up with a lot more supplies than you will vaccine. So anybody have any other questions that we missed in the chat or just something that's coming to mind now?
Hey, Jen, we did get a question about how to document Mrna 0.25 ml doses so it will properly transfer to ASIIS and inventory decrementing. Do you know about that, or do we have a resource for this person?
Yeah, I do know, and I have now heard someone else mentioned in the chat too that it's not working correctly. So you use the you use the billing codes that you would use for billing. You use those in your EHR to indicate that this is the half dose Mrna, and the half dose Mrna admin fee or admin code is different as well. So use those codes in the EHR, and then theoretically it connects to ASIIS. It understands that you've used a half dose based on that code and will decrement accordingly, but it is not currently working. And part of this issue we're finding with the health plans as well, these changes are happening so fast. CMS is having a hard time getting the codes up. We just got J&J's booster dose code yesterday. And the EHRs are taking a little bit to update their codes, and ASIIS is as well. The other thing that you're going to find is when you bill those codes in the next couple of weeks, that you may get denials from the health plans, because it's going to take them probably 4 to 6 weeks to update their systems to be able to pay those codes. So right now we're in that limbo time where all the systems are trying to update and it's not decrementing correctly. So I understand that some places are going in manually and adjusting the inventory based on that, that not decrementing correctly for the half dose. So in the meantime, do that. I'm waiting to hear back from ADHS to see what their workaround is for now and the timeline of when that'll be fixed. And we'll post that with today's handouts and slides.
Thank you.
I'm seeing here that it's, thank you. Yeah, I'm seeing here it says the third dose codes, but on our admin screen, it also asks for the dose number, and we're confused about how we should indicate these. Yes. Right now, we call it dose 3 for immune compromised people who need 3 doses in their primary series. And it's called a booster dose for anyone who receives one 6 months later for that booster. CDC did indicate this week that they anticipate that immune compromised will get 3 doses for their primary series and can plan to get a booster dose at 6 months. But there is also, you know, all those separate billing codes. You have to indicate that this is an immune compromised person. You need a note somewhere in your chart if you're billing Medicare to indicate this is dose 3 for an immune compromised. You don't have to do any other kind of charting for that booster dose for them. But they understand that it's gotten so confusing that we did see a CMS post not too long ago, a couple of days ago, that said they are considering calling all dose 3s the booster so that you could bill it either direction. But that hasn't happened yet, and we don't have any official word on that. If that happens, that should help with that, the administration screens for dose 3 or booster. It will no longer confuse them, we hope. Okay, let's see what was the second part of that question. Dose 3 for booster of the same presentation of the primary series. If it's a different presentation than the primary series, is that dose 1? No, it'll still be dose 3. You're just given a different primary or a different presentation. So you've given, let's say, 2 Mrna for their initial primary dose, and for their booster dose, you only have Pfizer on hand, so you give them a Pfizer. That is still a dose 3 and not counted as a dose 1. So you use the dose 3 admin codes for that vaccine, for that booster. Or dose 3 if it's immune compromised. You know, I know this is clear as mud, right? Getting crazy.
You're doing good. You're doing good. And all this information will be on our website also. I'll go ahead and post that link again.
It is, and I did update the kind of the slides that are the full billing guide that have the codes for all of these with a little bit of explanation of what you have to chart and indicate for that third dose on immune compromised. It's not a lot because it's patient attestation, but you know, you just kind of indicate that, you know, patient has confirmed that they're immune compromised, and that should cover it. Even your checklist as they check in, we'll do that for you. Any other questions? Anything else coming to mind? It is going to take a while for all of the systems to catch up. And, you know, like I said, they're kind of still changing things minute by minute. We thought that would taper off a little after we had the vaccine for a while, but it's not. I mean, we've been on the CMS website waiting for these codes. And as we're looking at the website, we have to keep hitting refresh because it's changing so fast. So if you feel like you're not following and losing your mind just a little bit, it's not you, it's all of us, and everybody's kind of trying to catch up. And everything we talked about today will be posted on the website. The website's taking a little bit to refresh and upload, but they are posted there. So keep checking back. In the next few minutes, it'll all be available to you. And if anything else comes to mind, feel free to reach out to us anytime, you know, email or call, or, you know, just ping us if you need to. Well, we're happy to try to track down those answers for you. All right. Well, thank you, everyone.